Hello and welcome to PMP Live. I'm Alan Watke, an event coordinator with Politics and Prose. Thank you for joining us in this new format in the midst of these unprecedented events, from the pandemic, which forced us all inside of our homes, to the worldwide police brutality protests that are now compelling us to get back out of them. Throughout all of this, we strive to continue to bring you the authors you love and their new books to the Politics and Prose community. At any time during the event, you can click on the green button below to purchase the long fix on Politics and Prose's website. Our physical stores are still closed, and we do need your online purchases in order to keep bringing you the programming PMP is known for. Today, you can ask the author a question by clicking on Ask a Question, which can be found near the bottom of your screen. You can also read other people's questions and vote on the ones you'd like to hear answered the most. Finally, we want to thank you all for being here with us today. We are so thankful to our family of loyal customers, keeping our business and our spirits afloat. Today, I'm very excited to welcome Vivian S. Lee to Politics and Prose. PMP Live, actually, not the actual bookstore, unfortunately, right now. Celebrating her new book, The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone. In which physician and healthcare CEO Dr. Lee cuts to the heart of the healthcare crisis. Dr. Lee has been a practicing physician, scientist, and healthcare administrator for more than 2 decades. President of the health platforms at Verily, which is Alphabet's health company. She is also a senior lecturer at Harvard Medical School. Formerly, she was a dean of the University of Utah School of Medicine and CEO of University of Utah Health, a system recognized for its excellence in innovation in care. And so, without further ado, please welcome to PMP Live, Vivian Lee.
Thanks so much, Alan. It's really great to be with you. And it's just wonderful to see also so many familiar names. Thanks for joining. I'm sure this will really enrich the discussion. You know, Politics and Prose is so legendary, even to those of us outside of the Beltway. So I'm really delighted to be with you, even though it is virtual, and I look forward to the day when we can all be in person. I'm planning on spending the first 30 minutes or so sharing some thoughts about this new book, The Long Fix, and then I'm really looking forward to answering questions and having a good discussion. What I thought I'd do in this 30 minutes would be to start with addressing why I wrote this book. And then I thought I'd spend a few minutes talking about how the book is structured and what it's about. And then of the 12 chapters, I thought I would dive more deeply into maybe 2 or 3 of the topics, depending on how much time we have, and then open it up for questions. So let me start with the question that I'm often asked, which is, why did I write this book, The Long Fix? And I wrote this book for 2 main reasons. First and foremost, because I felt like it really was time for people in this country to understand one of the most important issues facing our present and our future, and that by making it more understandable and maybe less mysterious, maybe less intractable, perhaps we could once and for all collectively have the will and the knowledge to really make a difference and to really do something about our healthcare system and make it one that can really serve us. So that's the first reason, to make a complex topic just a little bit clearer to everybody. And I had a head start. This book began as a series of presentations that I made to our brand new medical students back when I was a medical school dean. And these students were fresh out of college. They were new to medicine and healthcare. And actually, many of the questions that they asked me are the same kinds of questions that I get asked now at Verily, where I work, where the engineers and product design folks in this technology sector who are new to healthcare and just want to understand how this very complicated system that we call our healthcare system actually works and how they can make a difference. So that was my first reason. And the second reason was because from living more than 25 years in a variety of roles, as a doctor, researcher, as a CEO of a system, helping to found a health insurance company on biotech boards and nonprofit boards, and working very closely with all kinds of health professionals, including nurses and pharmacists and therapists, and now even in health tech. I have become a collector over the years, an accumulator, somebody who's really collected and cherished some really fantastic stories and ideas about how to fix our healthcare crisis. Sure, we hear all the time about all the things that are broken in our healthcare system, the rising cost of medications, balance billing or surprise billing, the lack of insurance, health inequities. But I think we haven't heard enough about the solutions. And so that really was my second goal, to share solutions for fixing healthcare, solutions that are proven, that have worked across this country. So it may sound like an oxymoron, but this is actually an optimistic book about healthcare, because these successes really lay the groundwork for a national strategy for healthcare for the long fix. So that's why I wrote this book. So now let me share with you a little bit about how the book is structured and what I talk about in it. So The Long Fix was really written to be an easy read, full of stories. I really favor a narrative approach through the eyes of people on the front lines, patients, doctors, insurance executives, public health officials, CEOs, community health workers. It is intended, it covers a lot of ground, hopefully without really feeling like it. I start by laying out the fundamental premise of the book, which is that the central problem in healthcare is its economic or its business model, which is fee-for-service, or as I like to call it, paying for action. It's not so much how we deliver care or even who is paying for healthcare. Both are important. But to prioritize, the number one problem to solve is what it is we are paying for and incentivizing. And in healthcare, we are paying for action. We are paying for people to do things to patients, not paying for people to help keep us all in good health. And that's really the root of most of our problems in healthcare. And I'll speak more about that in a few minutes. And also about how that really doesn't have to be the case. And in fact, there are some great examples where it isn't, even in this country. Then the rest of the book examines solutions for the long fix, and really in 5 main parts. So the first section of the book explains how, instead of paying for action, paying for better health would mean that we would invest much more in prevention and in primary care and in public health. For example, we might embrace the idea of the food pharmacy with an F, which was an idea that David Feinberg and his team at Geisinger promoted, or the Jewish Health Foundation of Pittsburgh's work with the Virtual Senior Academy, investing in online programs to keep seniors connected to each other, to combat loneliness and social isolation. We value these investments because the most cost-effective way of achieving good health is definitely through prevention and through public health. And this is a lesson we are all learning the hard way right now with COVID-19. A different model of paying for healthcare would also have a second critical benefit, which is that it would incentivize hospitals and physicians to work together with insurance companies instead of as kind of mortal enemies sometimes. And we know that model works much better. We have successes like Kaiser Permanente or Intermountain, those kinds of organizations where the payer and the providing system are one, as well as I'll talk about shortly, in military medicine. Another really great example is Medicare Advantage, where collaboration between the companies that are paying for healthcare and those that are providing healthcare are really making for much better health. The second section of the book looks specifically at how hospitals would act and should act if they were tasked with this different economic or business model of care, where they were charged with delivering value, meaning delivering what the customer wants and needs, which would be better health instead of just more procedures and things done to us at lower cost. And in hospitals and in clinics, this pivot in the business model would have and has enormous implications. So in the book, I start with safety, and I won't talk about it much today unless any of you have questions, but I just want to put out there that medical mistakes are the third leading cause of death in this country. The third leading cause of death in this country. Between 250 and 400,000 people are dying from medical mistakes in the US. That's 3 to 4 times as many as have died from COVID, for example, this year. And so I talk in the book about how hospitals that are paid in a different model to deliver better health are really forced to confront this issue and fix our medical mistakes and our systems, and how they can learn from industries like manufacturing or aviation to make healthcare better. I talk about how differently doctors would and do behave if healthcare is built around delivering better outcomes, and some great examples from, say, Geisinger Health or the Mayo Clinic or the University of Utah. And also in this section of the book, I talk about how hospitals completely redesign how they deliver care with patients at the center of the universe, and how they can use digital technologies like mental health apps and telehealth to deliver care more accessibly. And I'll talk a little bit more about that later if we have time. In the third section, I dig more deeply into 2 other major industries outside of hospitals, and that would be the pharmaceuticals industry and data and technology sectors, explain why drug prices are rising, and highlight the ways that we can think about or rethink about how we pay for medications, and also how big data can really accelerate the long fix. In the fourth section, I focus on the payers themselves and ask, what would it take for the payers, those who are actually paying for healthcare, to change the way they pay? I start with employers who pay for healthcare for more than half of all Americans and offer a 10-point action plan for employers to get on top of their healthcare bills. Actually, I have a piece coming out on Monday in the Harvard Business Review just on this topic. And then secondly, I look very closely at what government-run healthcare could do better. And in particular, I focus on the military health system and the Veterans Affairs, the VA system. And I'll talk a little bit more about the military health system shortly. They really offer a long list of lessons for the civilian sector. And then finally, in the last chapter, I roll it all up together in an action plan for the long fix. Each chapter, as I said, is filled with stories and ends with a specific action plan for everyone, from patients and their families to healthcare professionals to policymakers to payers. So that's kind of in a nutshell the summary of how the book works. So let me now shift into diving more deeply. As I said, of the 12 chapters, I'm going to pick 2 or 3 ideas that I'd like to share today and then look forward to the discussion. So the first idea that I really do want to spend a little bit more time on is the core idea, the one big idea of this book, which is what is fundamentally wrong and fundamentally can and is being changed, which is the business model of healthcare. So our healthcare system, we call it a fee-for-service system. I call it paying for actions instead of paying for health. So I'm an MRI radiologist by training, and in a traditional fee-for-service model, well, maybe not I personally, but my profession, we are often considered cash cows for the health system. So every time a patient comes in for that back MRI or the shoulder MRI or the knee MRI, we read the study, we perform the study, interpret the study, and we generate revenue for the healthcare system. And I and my colleagues get paid regardless of whether we are actually making anybody any healthier. That fee-for-service model is true across the system. So we are incentivizing people, healthcare professionals, to do more things to people, more lab tests, more imaging studies, more operations, regardless of whether it improves health. So for example, one of my pet peeves is back pain. Back pain affects so many people. The typical fee-for-service kind of care that an adult will get who has, say, just regular back pain, no neurologic problems, would be often an MRI, again, more revenue, and then a referral, say, to an orthopedic surgeon, and then often surgery. Each of those generates more fees, but the right way to approach uncomplicated back pain, based on research, based on the national guidelines from our professional societies, is just to advise patients to rest and maybe some physical therapy. So it's no surprise that in one of these systems where we just reward people for doing things and generating fees, that we have come to get very good at generating those fees. And healthcare is now about 18% of the US economy. We spend 2 to 3 times as much as our peers, let's say in Canada, in Europe, in much of Europe, say the UK, Germany, France, or in Japan, Australia, New Zealand. We spend 2 to 3 times as much per person on healthcare as those countries. And yet our outcomes are worse. Unnecessary back surgeries really don't make us any better. So the National Academy of Medicine and others have shown consistently that we waste about 25 to 30% of all the money we're spending on healthcare, 25 to 30%. Now, I just want to say that I'm not intending to imply that doctors and dentists and others are deliberately overdoing it, deliberately practicing bad medicine, but there's no question that hospitals and physicians that are incentivized to do more do more. And so what that means in our system is that the payers, the insurance companies, who on behalf of the government and employers, the only way that they can limit the spending is to put in place barriers. So they may deny care. Your doctor may recommend an MRI and the insurance company may say no. Or they may put in barriers called prior authorization, which is just a vast amount of paperwork that a physician might have to complete just to justify that MRI. And so every year, back and forth, physicians may make recommendations, insurance companies may deny, back and forth. There's a $1 trillion tug of war over the healthcare dollar, and it generates an enormous amount of waste, an enormous amount of administrative waste. In the US, we spend 8% of the healthcare dollar just on administration, whereas in most of those other countries I named, it's 3%. And where we can't resolve the disputes, those bills end up falling to the patients. That's the surprise bill. That's the balance bill that so many people are getting hit by. So we really need to change this model. And in a completely different model, we would pay healthcare professionals for keeping us healthy. And it feels like a radical idea, except it's already happening. And it's actually already proving successful. So one example is the Medicare Advantage model. So within Medicare, a new component of Medicare is called Medicare Advantage for our seniors. And within Medicare Advantage, there have been some special contracts that have been established between the government that runs Medicare, an insurance company like Humana, for example, that runs this business, and groups of doctors. And the way in which this Medicare Advantage model works is worth just a couple of minutes explaining. So the government basically will pay a group of doctors a fixed amount of money to keep their seniors healthy for a year. So instead of paying each time they come in, they give them a fixed amount of money and they allow the physician to decide how to spend it. So some of these groups, medical groups, include ChenMed or Iora Health or CareMore or Leon Med. These systems, how do they decide to spend the money? They practice medicine and primary care completely differently. They know that they need to spend more time with their seniors. So instead of rushing them through these 8 to 10 minute visits, they spend 30 minutes to even an hour with their patients. They have to see them. It's so important to keep in touch with them. So if their patients don't have transportation, they offer shuttle services. They have on-site pharmacies to make it really convenient. They even have yoga and Tai Chi classes because they know falls are really important to prevent. And those are very important fall prevention strategies, those classes. So these models are showing that by investing a lot upfront in primary care, our seniors can stay healthier and out of the hospital. And by staying out of the hospital, they actually save money in the long run. And as a result, those medical groups who are on the line for keeping people healthy within that fixed amount of money that they get paid, if the patient gets sick and they have to spend a lot of money on hospitalizations, they lose money. But in the end, they're actually able to keep those seniors healthier by investing in that primary care upfront. And it's just a much better model for where, again, the payers and the healthcare professionals are all aligned around keeping people healthier. So that's one example I wanted to share with you. And I should just mention that those systems are also much more resilient in the face of the COVID crisis. In the COVID crisis, Hospitals that just have to keep doing things to patients to generate their fees have had to lay off, 1.5 million healthcare workers were laid off in April alone. These systems like the Chen Meds and Leon Meds and the Insurers have really proven much more resilient because they have fixed income to keep people healthy. And so that not only is it a better model, it's also a more resilient model. The second example that I wanted to share with you is kind of an extension of that idea, which is an example of how this whole idea of paying for better health outcomes and not fee for service or paying for action can work at a much larger scale. And so this is a story of another chapter, one of my favorites in the book, which is towards the end, and it's called Restoring Readiness, Battle-Tested Care. And this is when I talk about government-run healthcare. Now, when we think about government-run healthcare, we may often think about Medicare or Medicaid programs. Those are really mostly benefits programs. So I wanted to highlight one government-run health system, the military health system. It's operated out of the Department of Defense, and it's responsible for providing health care for its 9.5 million beneficiaries. It's actually had a nearly flat annual budget over the last decade of about $50 billion. It isn't only responsible for health benefits and payment, but it also oversees the actual delivery of care in over 900 military treatment facilities, including 51 hospitals and over 400 medical clinics. And so that makes it both the payer and what we call the provider system on an annual budget. And now I won't make the claim that the military health system is perfect, but I will say that there are a number of lessons that we can learn from the military health system, and also, frankly, the VA, including a few that I'll share now. So first, they pay only for medications that work. They carefully examine their formularies, which is the list of medications that their beneficiaries and patients can access. They examine those carefully and look at the cost effectiveness of those drugs. And they actually negotiate with pharmaceutical companies for those drugs, which at the moment Medicare is actually not allowed to do. Another example is the military health system uses lessons from the battlefield to continuously improve and learn. There's something that I talk about called the Joint Trauma System that collects data from the field, and it has led to significant improvements in everything from how to manage hypothermia to dealing with major blood loss. And these lessons have actually really translated and benefited the civilian trauma centers enormously. Another example from the military health system is how they think about education as a vital part of the health strategy. And I'm delighted to see Art Kellerman joining, who is the dean of the Uniform Health Services University and the School of Medicine there. So the military actually invests in education and really expects service in return. I think that's a really interesting model, investing in education and expecting service in return. So their graduates, they don't come out of their training with the debt that most of us in the civilian side do. Instead of having hundreds of thousands of dollars in debt and then being forced to bill aggressively just to pay back those debts, our military health system actually pays medical students to go through medical school and to go through their training. Now, again, while the military health system isn't perfect, I will say one of the things that I love the most about the system, and I should mention that I do serve on the advisory board, the Defense Health Agency's advisory board, is that the generals and the admirals and the other leaders that I serve with all share this very profound belief that the military health system is strategically critical to this country's defense. This is about the readiness of our nation. The mantra of the Defense Health Agency is to provide a medically ready force. Medically ready force, your soldiers can't defend the nation if they're not healthy, and a ready medical force, meaning a medical and health community that is prepared to care for them. Think about that idea right now in the context of the COVID crisis. We need a medically ready America, and to do that, we need a ready medical system and public health system. So imagine if our government strategy was to provide for a medically ready America and a ready medical force to support them. I interviewed Vice Admiral Raquel Rocky Bono for this book. She was the former head of the Defense Health Agency. And I have a quote from her. She said, we should be targeting the readiness of all of our citizens, whether it's the firefighters or teachers or construction workers. All of our citizens really need to be ready to do what they're supposed to do in support of our society. And that's why it's imperative for us to really fix our healthcare system. So I've shared a few ideas about how paying for health instead of fee-for-service is such a vital concept and how it could work in this country. So let me just spend the last few minutes of this part of this session of PNP Live talking a little bit about how we also have some accelerators at our disposal to move more quickly to a healthier nation that costs less to keep everyone healthy. And for that, I'd like to turn to technology. The technology sector is one that I've come to get to know a little bit better. I work at Verily, which is a health company, but it is part of the technology sector. It's one of Alphabet's healthcare companies. And I want to talk about how technology is really helping us think about how we can care for people outside of the four walls of the hospitals and clinics. Many of us traditionally who grew up in healthcare have thought about healthcare as only taking place really in hospitals and clinics. But I think if nothing, we've really come to appreciate now with the COVID pandemic just how vitally we really need to think about health outside of those traditional environments. And in particular, I want to share with you an example of how healthcare can not only be delivered more effectively, but also in a more personal fashion through new digital health solutions. I'm going to talk about a particular product, which in full disclosure is a product that is made by our company, but it's really an example. It's one that I know best, but it's an example of the many digital health solutions that are out there. And in particular for type 2 diabetes. Type 2 diabetes is one of the most common chronic conditions. It is a risk factor for COVID and many other complications. And it is one that it's been very important for us to think very carefully about now that we are in this pandemic. So the virtual diabetes clinic that we have put together is called OnDuo. And it basically tries to provide all of the care necessary for a type 2 patient with a person with type 2 diabetes in the convenience of their own home. So it starts with a continuous glucose monitor, which is a small device. It's probably the size of maybe a key fob. And we happen to manufacture these for Dexcom, and others are also manufactured by other companies. And you can put this device on your arm or on your abdomen, and basically it measures your blood sugars 24/7 for a couple of weeks. So instead of pricking your finger to check your blood sugar, which is painful and definitely inconvenient, this measures your blood sugar all the time. It transmits your blood sugar to an app on your phone. And so on your phone, for the first time, people with diabetes are actually able to see continuously what their blood sugar is doing throughout the day. It's really pretty remarkable. Now, the most important thing that affects your blood sugar is probably what you eat and how you exercise. And typically, we might advise patients with diabetes or people with diabetes to keep a food log, a journal to record all their meals and snacks. I really think very few people actually do it. In this case, you can just take pictures of your meals and snacks with your phone. And so now you can see visually, you can make the association between what you're eating and how it's affecting your blood sugar. Really transformative. So that instead of the traditional way in which we approach it, which is to maybe lecture people, you really shouldn't be eating sweets, you really shouldn't be eating fast food, for example. Instead, the computer can actually, the software can actually say to you, Vivian, know that you really love that slice of pecan pie every Thursday night, or whenever. You can't resist it. But every time you've had that become habit, look at what it did to your blood sugar. And that kind of self-understanding of the biology of our health and our physiology is really transformative for people. Same with your exercise. It shows you how that changes. You can also text with a health coach and a video conference, just like we are with a physician. And so just from the convenience of your own home or work or when you're out and about, people are able to care for their own conditions, and in a way that is very personalized. We can see from the information from all these different patients that we work with now that everybody actually responds very differently to different foods. And so, for example, if any of you had a bowl of cereal with some milk, your blood sugar is going to be very different from how mine changes. So it's a personalized, much more accessible way of providing care. And as somebody who used to lead a health system in Utah with a large rural population, also much, much more accessible. These are now being covered by some insurers, and they really need more development and more investment. Other examples include, pregnant women really don't necessarily need to see the doctor every 2 to 4 weeks throughout their pregnancy. Much of it can be done remotely. Mental health and depression, really critical issues, especially right now in this country, much more accessible, and providing the care that people need when they need it. So one of the silver linings of the COVID crisis is that people who have had some reluctance to maybe trying some of these technologies, both on the patient side as well as on the clinician side, are really starting to open up to this. Many of the regulatory barriers are coming down, and even some of the payment barriers are coming down. I will say that for this whole space, this whole new area of innovation to really move forward successfully, in line with everything else that I talk about in this book, digital health needs to be accountable, not simply replace fee-for-service care. This is really a time to move aggressively into paying for better outcomes, and for digital health companies to show that they're able to improve health for people and lower costs, and not just simply substitute for fee-for-service. So let me just pause here. I shared a few ideas about how the fundamental business model needs to change for healthcare, and how it has already changed in many settings in this country. I hope that if you are coming from a policy background, that you can think a little bit about how programs like Medicare Advantage or the military health system can offer useful lessons for policy changes. If you're in technology, how digital health can really be a force multiplier. If you're an employer, actually I have a whole chapter, which I haven't talked about today, but a whole chapter on things that employers can really do, some really successful models there for driving change as some of the largest payers in this country of healthcare. And of course, we are all patients in this system. Most of us are born as patients into this system. And so I will finish with the words of one of my favorite people in Washington, D.C., Carolyn Clancy, who said, I think some very wise words. She said, "There is no drug as powerful as people engaged in their own health care and in their own health." So with that, I will stop my remarks. And again, thank you all very much for joining. And I look forward to the questions.
Thank you very much, Vivian. That was fantastic. I do want to encourage everyone out there to please click on that Ask a Question link and fill in your questions. So this first one is from Tony, and he says, "You speak positively about HMOs. However, except for Kaiser, most are not providing great care." Your thoughts or comments on that?
So I'm not specifically speaking about HMOs. I'm really speaking about models of care that are not fee-for-service, that are not designed where the healthcare professionals are paid to do more or paid for each service that's provided. So the Medicare Advantage model that I'm talking about is actually different from a traditional HMO. It's even more, I think an HMO was the first step. And I'd say the Medicare Advantage models that I'm talking about, which are a subset, maybe just to be clear, they're a subset of all Medicare Advantage. Not every Medicare Advantage program is like the one I described for Iora Health or for ChenMed. So in a subset of Medicare Advantage programs, the government pays this fixed amount of money to the medical group. And then the medical group is really incentivized to keep you healthy, because as a senior, you can actually sign up for a different program next year if you're dissatisfied. They're also held accountable to meeting certain quality metrics. And it's really in those models that we see, I think, the most dramatic change in terms of how healthcare is delivered. And that's why I really focus on that Medicare Advantage model. Also, for example, on hospitals that are paid a fixed amount of money for their entire population of people that they're cared for. Those are the lessons I think that we really need to take home from that part of the book. And we are seeing now actually increasing a lot more conversation about this. I know this is probably a little bit more in the health policy space, but there are a number of reports now of health insurance companies following the lead of Medicare Advantage of this model. And also that many of them have actually already innovated in this space and had pilot projects to begin with, but really pushing more aggressively now in the during COVID and hopefully in the post-COVID period to do the same, to really say, hey, you know what, we're seeing that these hospital systems are not robust. They're really not resilient with this fee-for-service model. Let's think about paying them differently. Let's think about paying these medical groups differently. It'll take a few years, I think, before we as individuals, as patients and our families will see this difference, but I think it's really important to understand that it's happening.
Fantastic, thank you. Art says, Vivian, thanks for mentioning the military health system in your book. Given the huge cost of medical education, can you speak for a moment about the value of national service scholarships? Is that a model that could work in civilian and med schools?
That's such a great question, Art, and thank you for asking it. I wish we were in real life, in person, because I'd love to have your thoughts also on this. So what Art is referring to is the fact that, as I mentioned, in the military, whether you are a part of the Uniformed Services University or whether you're actually on one of the scholarships that the military provides, you are able to have essentially your medical education free. And in return, you have to return by performing service back in the military. And we know that there's so many areas of this country, so many communities who are underserved, who do not have access to good health care. And so this idea of replicating or extending that model to the civilian sector so that people can come out of medical school without debt. The average debt, actually, I'll just share with you, the average debt of a graduate in medical school in this country is now $150,000. That's just medical school. It doesn't include the debt from their undergraduate too, if they accumulate debt there. And so naturally, they come out and it's a huge burden. Several of my colleagues have only recently paid off their medical school debt. So it just drives the wrong kind of incentives. It forces people to think about much more lucrative professions instead of primary care. Instead, as Art is suggesting, there's a huge opportunity for us to think about investing in scholarships for students who are committed to performing service, to contributing back, to paying back, and performing national service after graduation. And we have an enormous need in rural areas and urban areas and underserved communities. We have huge needs to address health disparities and health equity. And also, having been the dean, and I'm sure that Art feels the same way, there are so many young people now coming into healthcare, and I think we'll have even more with this COVID pandemic, who are really motivated to do the right thing, who are really motivated to help others. And so I think this would be a really, really fabulous idea, and would be an important way to help ensure that people who are very worried about accumulating debt and might feel that they can't come into medicine as a result. I think it could really help to ensure that we have better representation in our medical schools of people from all of America. So thank you for that question.
Yeah, thank you, Art. And I do want to encourage other people to ask a question in that little link right there. I'm actually curious, how do you see like the aftermath of the pandemic changing doctor visits to like a more virtual platform once things kind of normalize? Like, what are your thoughts on that?
We're seeing so many changes in healthcare that I think we would never have imagined could have taken place so quickly. So there's a little bit of a silver lining. The technology to do telehealth, to have virtual visits, has been around for a long time. This is not brand new technology that we're using now. And in fact, actually, as a radiologist, we were doing teleradiology 20-some years ago. So I was, for example, reading MRI studies from Michigan or from Wisconsin or California, even though I was seeing it in New York. But there were huge barriers to doing it, which really didn't make any sense. But I can, for example, I'll give you one example. In order to read an MRI, I could read an MRI from New York, of course, because I was in New York. But to read an MRI from Michigan, the exact same set of images, nothing particularly different about it, I would have to get licensed in the state of Michigan. So in order to do telehealth, until last month, I would have to get credentialed in every single state that I was going to video conference with a patient or look at their MRI studies, for example. And that's a huge, for those of you who haven't done this, I'm going to say it's really a huge amount of bureaucracy, a huge administration. You pretty much ask every single thing that ever happened to your life. That requirement just went away. With the COVID crisis, because we knew that we needed to provide telehealth to people. We needed to create more efficient and effective systems. Many of us who have been in medicine for a long time, we're a little slow to change. We kind of like doing things the way we've always done it. So part of what's happened also in COVID is that we've just seen rapid adoption. So most health systems who were doing maybe a few hundred telehealth visits a week are now doing hundreds of thousands per week. So we've seen physician behavior change, nurse behavior change, but also patient behavior change. People are much more willing and open to this idea. And I hope that it will extend. We were pretty sure, Seema Verma, the administrator for Medicare and Medicaid, CMS, suggested recently in an interview that it's likely that many of these changes will remain even post-COVID. And I think it's really important for us then to think, well, beyond the ability to talk with a clinician through telehealth, how do we ensure that we have the other components of keeping people healthy outside of the hospital and clinics? And some of the technology would include things like the blood glucose monitors or blood pressure monitors or temperature monitors, for example, if we're worried about infectious diseases like COVID. And so all of that technology needs to continue to grow and develop. And I think there's a huge impetus for that right now. Lots and lots of innovation going on, which is really, really exciting.
Fantastic. Thank you. It looks like Cheryl said, in your book, do you look at the FQHCs or HRSA Health Center program as a model for value-based care? I am biased, but think that they are awesome. Also, Carolyn Clancy was once my boss. Love her as well, a very brilliant woman.
Oh, well, thanks for sharing that, Charles. So we have to form we're both members of the Carolyn Clancy fan club then, for sure. And I'm sure many others on this call as well. Actually, I don't spend that much time talking about it, but you've made a really good point. I do. There are a number of community-driven programs that have been established over the years that are funded by Health and Human Services that really it really are offer almost the same kind of narrative that I just shared with you before about, say, the Medicare Advantage model. Many of these have also proven to be great case studies and examples, for example, for Medicaid programs across the country. So I really thank you for sharing this point, because I think it's a really, really important one. I also, as we're talking about this, I want to call out the work of Mandy Cohen, who is the Secretary of Health in North Carolina. I'm also a member of her fan club. I'm a member of a lot of fan clubs, actually. But she has done also, I want to say, some fantastic work in building not only some of the healthcare delivery programs, but some of the lessons that we've learned from the federally qualified health centers and other programs on the social determinants of health. And I think it's really worth mentioning that she's bringing together data from all kinds of sources from across the state of North Carolina, and enabling her beneficiaries, her Medicaid beneficiaries, not only to access better care, but also to be able to find resources for, let's say, for food stamps, legal aid, for housing assistance, all of the other really critical components that contribute to better health. So there's a lot of fantastic work that's being done across the country like that. So thank you. Yeah, thank you for that question.
Yeah. Awesome. Well, I think my last question that I like to ask every author is, what books are you reading right now, or would you like to recommend for like these unprecedented events that are keeping your mind on it, focused on it, or maybe like escaping from at the same time?
Oh, that's such a great question. So on the escape side, I love to read Bill Bryson. So I've been reading basically one Bill Bryson after another. And I haven't read the one about the body. I know everybody's been asking me about the body. That may feel not as escapey for me as some of his other books, but the Shakespeare book is really, I've just read that recently, and that's really been a favorite. And then I've been reading Ron Chernow for some reason. I just finished Titan, the biography of John D. Rockefeller, and now I'm reading Hamilton. Actually, one of the reasons why I'm reading Hamilton is because, of course, my whole family has been ardent fans of the musical, and I actually have a cousin that's been performing in Hamilton, so just little fun factoid. But I'm also very interested in kind of what the founding fathers were thinking about for this country, and just sort of reflecting a little bit on how our government is serving us, and maybe what was intended and maybe what wasn't intended. Anyway, so I'm reading Chernow, Hamilton.
Yeah. Wonderful. Thank you so much, Vivian. Dr. Lee, this is just fantastic. It's a great conversation, and I want to thank everybody that joined us today for this conversation. It was just great to have you all here. It's your patronage that enables to bring us programming like this, and we cannot continue to do these types of events without book sales to support them. So please do click that little green button below. Purchase the long fix straight through Politics and Prose website, and you're supporting Vivian, and you're supporting Politics and Prose. Also, check out our website for the most current updated event listings. We have a whole roster of events coming up, so please do check that out. And I want to thank you all for joining us today, and I encourage you all to just stay well and stay well read. And see you next time. Thank you very much,
Thank
Dr.
you.
Lee. Thanks,
everybody. Keep well.